Welcome. Welcome to this meeting in support of those living with Lyme disease. My name is Shireen. Phil Kenny and I established this center with the goal of providing information to facilitate the journey of those healing from Lyme disease or those supporting them. Our belief is that Lyme affects body, mind, and spirit. Any path to balanced healing must address each of these, as affecting one necessarily affects the other. Chronic illness can be an isolating experience, so our center also serves to remind those journeying with Lyme that they are not alone. It's time again to highlight the awareness of Lyme disease. Over the past 50 years, awareness of Lyme disease has increased along with the incidence rate. However, these two have not been commensurate. Lyme cases, especially initially, far outpaced awareness of this life-altering condition. Of course, it takes time for a seemingly new condition to become an established part of mainstream medicine. But even as more and more people suffered with this illness, awareness and action on the part of the medical community did not grow concurrently. Several factors have been contributory to this unequal growth. Huge numbers of cases with science playing catch-up, a wide range of sometimes vague signs and symptoms, countless cases remaining undiagnosed for long periods, inadequate testing contributing to a lack of biological proof, differences in rates of recovery, a healthcare system that allows minimal time for interaction to explore anything imprecise, reimbursement limitations based on a lack of evidence, and evidence that cannot be recognized while caught in the disconnect of that very healthcare system on which it must depend. But let's go a step beyond these contributing factors. Awareness of the long-term consequences of Lyme disease has also not kept pace with reality due to obstruction and minimization. Without supporting evidence, but with strong conviction, some have insisted that nearly all cases of Lyme disease are easily diagnosed and easily treated, and that any long-term sequelae must be caused by something else, including by factors under the patient's own control. Papers have been published wherein this dismissive fallacy is either overtly promoted with dogmatic statements or covertly presented between the lines of studies which have been designed to limit unwelcome results. Others then take this published information at face value. They quote it, they reference it, they rely on it. The spiral of misinformation continues while the population struggling to be heard, validated, and helped experiences the collateral damage. But what also suffers as the cycle is perpetuated is the scientific advancement of Lyme disease. The purpose of science is to observe, to describe, to build knowledge based on rational hypotheses and objective evidence. Endeavors which begin with the primary purpose of advancing an opinion, despite contrary evidence, are no more than confirmation bias from the outset. And even more fundamentally, science cannot prove that something is non-existent. An endeavor commencing with the proposition that something does not exist, that something cannot be, well, that's already exited the arena of science and entered the stands of propaganda. There is no fault in not having all the answers or in maintaining a healthy dose of uncertainty during the discovery process. The history of scientific discovery is replete with examples of firmly held beliefs no longer standing up to scrutiny. But rather than insisting on what this increasing mass of post-tick bite suffering is not, valid efforts to contribute to what it could be will move the science of Lyme disease forward. There are things we don't know that will unveil themselves as fact, and there are things we presume to know that will reveal themselves as fiction. The path from here to there is not often linear. It is full of curves and tangents, enticing the follower with offerings of evidence. It only makes sense then that true science is that which remains in harmony with the data, follows a path of inquiry to wherever the data leads, and corrects its course as necessary, always remaining open to the provisional nature of its own truth. Enter our guest speaker for the evening. While in private practice, John Aucott took notice of the many clients he had who were healthy, energetic, and vibrant prior to being infected with Lyme disease. He took what he was learning from his clients and made it his mission to be honest about what we don't yet know and to find out more. To take this ever-expanding group of often marginalized patients and examine the common thread in their narratives in a systematic and multidisciplinary way. He and his team of dedicated researchers and clinicians at the Lyme Disease Research Center have made incredible strides. They've carried out numerous clean and precise research studies which have moved us all forward in our understanding of Lyme disease. The advancement of Lyme disease science is due in no small way to John Aucott and his team's incredible contributions. I'm going to pass the screen now to our director, Gina, for her update and welcome.
Thank you, Shireen, and welcome everyone. I want to say with so much gratitude how meaningful it is for me to be here tonight, celebrating 8 years in this month of Lyme disease awareness and the 8th year for this nonprofit. And to be a part of this nonprofit and to be a past patient is one of my greatest honors, to be able to be in a role where I'm giving back as I'm living and learning. But Phil and Shireen established this nonprofit with similar passions, having experienced Lyme disease firsthand and the challenges and the sufferings that one goes through, and really stepping aside and looking at the bigger picture of what can we do to learn and grow and give to others. And I just want to welcome everyone that signed on from all of your homes, all of your workplaces. It means a lot. And we're all giving our time tonight. And time is such a precious gift. And when we think about time to connect, time to listen, time to share our support, time to give our gifts. And you know, as the Lyme Care Resource Center strives 8 years in to bring hope and healing to each individual, each family member, each person that signs on for all the right reasons, we really value the opportunity to provide uplifting resources and quality education through these webinars. We try to highlight research, science, and also other alternatives, as Shireen was mentioning, with mind, body, and spirit. It's important to consider all options and to educate ourselves and guide ourselves as we make the best decisions as we strive for optimal health. From a patient's perspective, I wanted to say something to every patient, every individual that has been impacted by Lyme disease. It's really challenging to navigate this journey, and it's very difficult to put it into words. But it's important to say out loud and on a meeting like this, as we listen and learn together, to really say that every patient has their own story and it's significant. It can be really overwhelming and isolating at times. It can be really joyful. And when you focus on the strength and the resilience that is developed in the journey, that's a beautiful thing. But for a patient trying to develop relationships, sometimes with new doctors that have never met them before, new healthcare practitioners, they're trying so hard. We're all trying to advocate for our health and we're sick. And sometimes it's very difficult not only to put into words what we're going through, because it's a multitude of challenges. And it can be very isolating and lonely and scary. And it's okay to say that, even though our focus is on, you know, healing and hope and resilience and strength. But I just wanted to say to every patient that signed on tonight to learn and to be guided in your decisions moving forward, we want you to know you're validated in your experience. And we want you to know that you're not alone. We're not meant to go through life alone, so don't. We're so happy to have you here. You're special to us. We care about you and you're loved. So welcome everyone, and to all the patients and the doctors and the family members, other healthcare practitioners that signed on to listen and learn together. We're grateful for you, and we really are going to sit back and reflect on overcoming and what we can do to give ourselves a special hope. So we adopt together a chosen positive mindset. That's one of the core pillars of this nonprofit. And what Phil and Shireen worked so hard to establish. So one of the reasons that we're all here is this unbelievable dedication of Dr. John Aucott, responding to the needs and the challenges of this disease, and many of the patients that felt like there wasn't enough support, there aren't enough answers. And we just want to thank him for this 8th annual update that he's prepared, and really say thank you to Dr. Aucott, Nancy Doherty, who will be on this call facilitating the question and answer portion after the keynote talk. We want to thank both of you on behalf of the entire center for all of the hard work over the years, the passion, the creativity that's needed to pursue the research, the discovery, the innovation, the identification, the education, and ultimately the treatment of Lyme disease. Your work gives our nonprofit and our supporting community so much comfort and a special hope. And I want to save the rest of the time for Dr. Aucott, but we are so honored to have you back again. Thank you for preparing a special talk for us, and we can't wait to hear the updates. So at this point, I'm turning the presentation over to Dr. John Aucott. Thank you so much.
Gina, thanks so much. It's really great to be here. I'm always so encouraged when I hear your opening remarks and Shireen's, and I just thank you guys and Phil and Nora Kenny. It's been a long journey that we've had together, and it all starts with taking care of patients and people taking care of each other. So I still see patients. I'm an active clinician in the context of the Lyme Disease Research Center at Hopkins. My disclosures don't affect my talk today. Emergent tick-borne diseases are emerging infections, and they continue to emerge throughout my career. We're going to be talking mostly about Borrelia burgdorferi infection spread by Ixodes, but there's other infections spread by Ixodes scapularis, Powassan virus, Anaplasma, Babesia, and this is Borrelia miyamotoi. It's actually this long guy's Borrelia miyamotoi, but you can see right next to it actually Babesia as a co-infection. So this patient actually has a co-infection of Babesia and Borrelia miyamotoi. And then the Lone Star ticks, amblyoma, unfortunately, are spreading rapidly in the United States, all the way up and down the East Coast, up into even far north of New York. And that spreads a disease called STARI, Southern Tick-Associated Rash Illness, which the rash here looks a lot like erythema migrans of Lyme disease, but spread by Lone Star ticks. And then you probably know that the alpha-gal meat allergy is spread by Lone Star ticks. So, tick-borne diseases, infections, and non-infectious diseases are really, unfortunately, spreading geographically and are, rampant in the United States. This is a map showing the worldwide nature of tick-borne infections, originally discovered in Europe and then North America, and now being explored in the Southern Hemisphere. So these are really worldwide infections that really nowhere, is exempt from tick-borne infections in the world. Tracking cases has been difficult. Hopkins School of Public Health started this Lyme tracker because it's been difficult to track cases using CDC data. We all know that CDC data in the 30 to 40,000 range is about a 10-fold underreporting. So the true number of cases is more like 400,000 to 500,000 cases a year. Problem is tracking is difficult. You can see in the map here that Massachusetts stopped reporting cases at one point. So the tracking through the CDC is difficult. We're exploring ways to track cases better. One of the things we're getting ready to publish is using Google search engine data to track cases through people's Google searches, which is a promising way to track cases. The other way to track cases is through companion animal data, dogs and other companion animals. And it shows similar maps to what you'd see for human cases, but actually the animal cases tend to predict the leading edge of the cases, so that you can see that the animal data predicts correctly that Lyme disease was moving down through Virginia and now into the upper part of North Carolina, into Kentucky, West Virginia, and now into Ohio. So we need better ways to track cases and companion animal data has always been kind of a forecaster of the leading edge. We're finding the same leading edge through our Google Trends data, so that we know, for instance, in Michigan, up along the west coast of Michigan, now there's Lyme disease in the upper peninsula of Michigan. Ohio is being approached from both sides, and then on the west coast, there's Lyme disease and tick-borne disease. So, you know, lots of tracking and better ways of tracking need to be developed. Back in my envelope calculation is about half the US metropolitan areas are in Lyme endemic regions now. If you don't believe that, here's the Golden Gate Bridge with deer coming in from Marin County into the city. So it's both a rural and peri-urban disease. This is a map of Maryland and Baltimore cities down here, but you can see these river stream beds go all the way into the city. And even though I'm out here in the hotbed of Lyme disease in Baltimore County, the cases commonly come from the city because of Falls River and different river stream valleys that go into the city. The same thing is true in Washington, D.C. and many other cities. So it's both it's not just a rural disease, it's a peri-urban and even urban disease. And of course, people from the city go fishing at the reservoirs on the weekends. So half the metropolitan areas are in high risk regions right now. Climate change is affecting tick-borne diseases. It's allowing tick-borne diseases to move north in the northern hemisphere and also to higher elevations. And this has been seen now in North America and Europe. And a group that's spent a lot of excellent research showing this is the Canadian epidemiologists and tick biologists that have shown that Lyme disease has moved up into Canada, into Nova Scotia and Ontario, and this has been happening under their eyes as they're tracking ticks and cases. So the warmer climates allow the mice populations to expand and have longer seasons, and of course the mouse is a reservoir for Borrelia burgdorferi. So climate change is increasing the amount of cases in the northern climates, the Upper Peninsula of Michigan and Canada. So it's Lyme season right now. We've had our first 3 cases in the last 2 weeks. That's because the nymph stage ticks of Ixodes scapularis are out starting to feed. They come out like clockwork every April, May, and they feed. Unfortunately, they're quite small. This is the infamous CDC poppy seed muffin public service announcement where they put Ixodes nymph stage ticks among the poppy seeds. And your task is to find the ticks among the poppy seeds. And you can see these poppy seeds with legs are the Ixodes nymph stage ticks, about the size of a poppy seed. So it's very difficult to see nymph stage ticks. It's almost easier to feel them, but tick checks are important. I'm not going to talk about prevention today, but if there's questions in the chat, we can answer them later. The key thing is look and feel for ticks after you've been outdoors and take an appropriate prophylaxis. A tick bite is not like a mosquito bite. We've been involved in some research on tick bites. Ticks, of course, feed for multiple days. They establish a feeding cavity. During the process of feeding, they secrete proteins into the skin that can cause things like alpha-gal meat allergy, can cause allergies to the tick bites. Are working with some investigators that are looking at tick bite vaccines that are meant to vaccinate people not against the pathogens in the tick, but against the proteins that are secreted by the tick during feeding. So tick bite vaccines are an area we've been involved in and are promising because of their ability potentially to prevent not just one pathogen, but multiple pathogens by creating an allergic reaction to the tick bite that causes the tick to fall off or be noticed and to prevent transmission of the pathogens. So tick bites are a complex biology that's very important to understand, and research on that is important. Tick bites cause reactions. This is a classic tick bite reaction. They're very important to recognize because that means you've been bitten by a tick. Most people don't see the actual tick, but they often see the tick bite reaction after the tick has fallen off. This is different than the erythema migrans rash of Lyme disease. These tick bite reactions can last for weeks, and they need to be watched carefully for the development of erythema migrans or a feverish illness. There's also the potential for doxycycline prophylaxis for a tick bite in the first 72 hours. prophylaxis is different than treating Lyme disease. Prophylaxis is meant to occur in the first few days to prevent transmission from the tick bite. So tick bite prophylaxis is something to be discussed with your physician if you find a tick or remove one in the first 72 hours. We get called about lots of things this time of the year. I just thought it would be informative to show you what kind of calls. We have a rash hotline that Cheryl Novak mans, and this rash hotline takes lots of calls. We tracked that during the COVID telemedicine period, and you'd be amazed the number of things that Cheryl gets called about. So she gets called about ticks that are still attached. So that's not Lyme disease because the tick is still there. She gets called about tick bite reactions that aren't Lyme disease, but are evidence of a tick bite. And she gets called about small lesions that are enlarging after a tick bite that may be on their way to developing Lyme disease, but are still in the incubation period. Of course, she gets called and gets pictures of full-fledged erythema migrans. It's bigger than 5 centimeters, often 8 to 10 inches in size. And she gets called by people with multiple erythema migrans, and this young man also cranial nerve Bell's palsy. So all these things come in over our rash hotline. We also get calls about Lone Star tick bites, and occasionally the rash of the Lone Star tick bite called Starry. And we also get called about rashes that aren't tick bite related, that aren't Lyme or anything else. This is a classic bacterial cellulitis due to strep. So all these are in the differential diagnosis of what people see this time of the year. And I'll just tell you, take a picture of it, because that's the way your physician can help you figure out what it is. And if you're in our region, we have a rash hotline, and we see patients urgently for these cutaneous manifestations of tick bites. So I'm going to transition now to Lyme disease, full-fledged Lyme kind of 101 here of the kind of phases of Lyme disease when it's untreated. The tick bites you. The incubation period is about 7 to 10 days. And during that time, the Borrelia burgdorferi is multiplying in the skin where the tick bit you. The spirochetes are starting to enter the bloodstream, and the rash forms at the site of the tick bite. The rash without treatment actually goes away in several weeks because the immune system is starting to fight the bacteria in the skin. And the rash actually without treatment goes away. The problem is in over half the people, the bacteria have traveled through the bloodstream to other areas of the body during that initial phase. Without treatment, the likely places that will then appear next in the second phase are the nervous system, meningitis, or Bell's palsy, the heart in the second stage. And if that isn't recognized, or if there isn't treatment of any of these stages, the third stage occurs on an average of 6 months later with late Lyme swollen knee arthritis. These are all manifestations of untreated Lyme disease where the bacteria are present in the joint, in the nerves, in the heart, in the skin, because Lyme disease, Borrelia burgdorferi, causes a chronic infection without antibiotic treatment. And that's chronic out to 6 months to a year in over half the people that develop Lyme arthritis. So this bacteria is a professional immune system evader. It is not eradicated by the immune system in over half the people and causes chronic infection without antibiotic treatment. So that's the natural history of untreated Lyme disease that we see all phases of and are part of our research. I'm going to start at the first phase, though, and a paper recently published by Allison Rebman and our network. Allison is one of the co-directors of the Lyme Center, is a brilliant scientist that's in large part responsible for the success of the Lyme Center. And we had an observation that my observation is that, patients often present with symptoms before their rash appears. And these are the types of symptoms in acute early Lyme disease: fatigue, myalgia, headache, fever, chills, sweats. Sometimes these happen before the person has a rash. And so all they know is that they're sick, but they don't know if they have a rash. So we did this study where we separated the patients into people that had a rash at the onset of an illness and the people that had symptoms before their rash. And these symptoms often preceded the rash by several days. And we wanted to see if there was a difference in the way they were diagnosed, if you had the rash first or the symptoms first. And it turns out there was a huge difference. looking at disseminated rash, in other words, a sign of dissemination to second stage Lyme disease, if you had the solitary single rash first, only a quarter of the people developed disseminated lesions when we saw them. But if you didn't have that erythema migrans rash as your initial manifestation and just had symptoms, the symptoms were often ignored, and 40% of the people presented to us with already disseminated skin lesions. In other words, what had happened was, we found, is that they had initial misdiagnosis. The lesion, skin lesion first people, only 10% had been misdiagnosed, which is too high, obviously. But if you didn't have the skin lesion and only had the symptoms, 21% of the people had been misdiagnosed by the time we saw them. So this was a really important observation, because what we were seeing is, if you go to an urgent care center with fever but don't have the rash, or they don't see the rash because you aren't examined properly, you're very likely to get misdiagnosed and allowed to proceed on to second stage disease. So the symptoms first group is the high risk group. But even if you have a rash, we still see a lot of misdiagnosis, because everyone's looking for the rash that looks like the side of the Target department store. But they don't look like that. They're rarely this classic ring within a ring. They're more often just round and oval and red. Sometimes they're blistered in the middle. They're often hidden behind the knee. And the range of rashes is quite diverse. Only 20% have that classic ring within a ring. We published an atlas kind of, or characterization of all the different forms of rashes. And you can see they're often bluish red and look like bruises. They sometimes have blisters. They're sometimes darker in the middle, sometimes clear in the middle. They can look like almost anything. They're always round or oval, but the coloration is highly variable. In dark-skinned people and African Americans, rashes can be quite difficult to see. This is a case report we published about a man who was misdiagnosed because his rash wasn't seen. Again, that theme of not seeing the rash, and he progressed to meningitis because of delayed diagnosis. This is a big problem. We found that in African Americans and dark-skinned people, people of color, that it's hard to see the rash. So Allison again published a paper looking at the diagnosis of Lyme disease in African Americans, and looked at the difference in presentations between Asians, blacks, whites, and other races. And what she showed is that if you look at the blacks and how they present in this bar here, they present with the rash only far less frequently than whites do, and less frequently than Asians or others. So again, African Americans are not being caught at that rash only stage, which again, we pointed out is when you want to catch it. Instead, the African Americans are being diagnosed after they have disseminated disease, and that's often neurologic disease or arthritis. So having dark skin is a risk for not having your rash recognized, and it leads to delayed diagnosis. The reason people don't understand what the rash looks like is because they're hard to see. And actually, there's very few images of erythema migrans rashes in the medical literature or in the teaching material that doctors and nurses are trained by. And because of that, we desperately need more images of erythema migrans in dark-skinned individuals. If you have any of these, we would love it if you contact us, because we're trying to expand the collection of these images for teaching and education purposes, and also for use in AI models of computerized rash recognition. So first stage symptoms followed by rash. Second stage, disseminated lesions with spread of the bacteria through the skin into the nerves. And so this is where second stage we have neurologic disease and cardiac disease. The skin lesions that are spread through the bloodstream can be quite variable, because now we have secondary skin lesions, and these are often missed because they don't look, again, like the classic single bullseye target lesion. And when they spread to the heart, and this is a picture of the bacteria in the heart, this is a major cause of mortality with Lyme disease. And every year there's several cases of sudden cardiac death reported due to involvement of the heart, so-called Lyme carditis during the second stage of disease. Of note, these 3 cases presented here, none of them had a rash noted. So these were the kind of people that had symptoms without a rash. Again, that theme of symptoms don't lead to a good diagnosis. And without the rash, these people disseminated to the disease to the heart and resulted in cardiac arrest. We're studying with our cardiologists here at Hopkins the role of Lyme disease, both in acute heart disease, but also in the potential to be associated with dilated cardiomyopathy. And working here at Hopkins with Adrian Branchek up in Canada, we started a group to look at cardiac manifestations of Lyme disease and to look for biomarkers of early heart involvement with disseminated Lyme disease. So we're going to transition now a little bit to diagnostic testing. Diagnostic tests are still in their primitive stage. The tests are antibody-based tests still that are on the market. They have false negative rates that are very high in the first few weeks of infection. That's because they have to depend on the development of antibodies from the immune response, which takes weeks to occur. So because of that, antibody-based tests are most helpful in people that have had symptoms greater than several weeks and prior to treatment. So they're not very helpful when you first present with those symptoms that like fever or the rash. These antibody tests are also not useful for monitoring therapy. They're not a test of cure because they're indirect. They measure the antibody immune response, not the actual infection. And your immune response, your antibody response has a memory. And so that memory lasts for months or years and does not act as a test of cure. And what's not widely known, but is really crucially important, is these antibody tests also are unpredictable after early treatment of Lyme disease. So the tests don't always become positive if you have early Lyme disease and receive antibiotics. They may stay negative or become negative. And so they're not reliable in the setting of prior early treatment. The flip side is if you have a positive test, they can stay positive for months or years. So antibody indirect tests are not what we want. We need better tests. There has been a modification in the 2-tiered tests that you should know about. It used to be an ELISA followed by a Western blot. That's being widely replaced now by an ELISA first tier being followed by a second tier second ELISA test. So you're going to see less Western blots as a second stage of the 2-tier testing algorithm and more second ELISAs. It's a different ELISA. It's not measuring the same antigen antibody response, but it's still an antibody response. So I'll tell you, even though you'll see these different tests, they may be slightly better, but they're still an antibody response, and they suffer from all those problems of antibody-based tests that I just told you about. They're not sensitive in the early phase. They don't become sensitive till the later phases in arthritis. But the problem is, again, is that after treatment, what would be called the convalescent phase, if you have an acute phase illness that's treated with antibiotics, the IgG in the convalescent phase, 3 to 4 weeks later, is usually negative. So they don't perform well in people that, even if you wait 4 to 6 weeks, if they've been treated in the early phase with antibiotics. So lots of problems with antibody-based tests. We need better tests. Fortunately, there's actually a lot of people working on diagnostics now. It's been quite, one of my themes tonight is things are getting better. I know it's hard to understand that because things move so slowly, but there is a lot going on in Lyme disease research. One of the big things that I've seen over my career in the last 10 years, especially, is a lot more people working on improved diagnostic tests. One of the things that's highlighted this is the LymeX Diagnostic Prize, which is a U.S. Department of Health and Human Services co-sponsored with the Stephen and Alexandra Cohen Foundation competition for development of better diagnostic tests. The 5 phase 2 winners were just announced. 1, 2, 3, 4, 5, 6 actually, and moved on to phase 3. And these are the companies or academic partners that are working on improved diagnostic tests. And many of these are direct diagnostic tests or improved indirect tests. And so these are really smart people, really mainstream players that are working on much improved tests, and they're being stimulated by competitions like this LymeX competition that offers prize money and stimulates the quest for new FDA-approved tests. So I'm very encouraged by this. I know almost all of these competitors. We work with half of them, and they're doing really good work. So let's move on to treatment. Treatment of tick-borne diseases is the mainstay is oral doxycycline. The big change recently is that doxycycline is really being recommended for all ages now, not just adults, because of the lack of significant toxicity in children and the need to make sure that organisms like anaplasma and Rocky Mountain spotted fever get covered, because Rocky Mountain spotted fever is not treated with amoxicillin, the alternative to doxycycline. So doxy should be the first line choice. And we do treatment of complicated cases, so we also use intravenous antibiotics for complicated cases, which is indicated for complicated cases as well. So treatment has not changed much. And that's also a problem. That's something we need to talk about, because when you talk about prognosis in Lyme disease, I showed you the classic, manifestations of untreated Lyme disease, and treatment prevents those classic objective later stages in the majority of the patients, but not in everyone. And for instance, 10% of people treated for late Lyme arthritis develop persistent inflammatory arthritis. 10 to 20% of people treated for early stages of Lyme disease also develop persistent Lyme disease associated illness that I'm going to talk about now, because this is what we study at the Hopkins Lyme Center. It's that 10 to 20% of people that, despite treatment, even early treatment, still don't get better. They developed an illness after their Lyme disease, after the initial treatment, that is not their health the way it was before. So that's what I'm going to be talking about now, because that's the main area that we do research on at Hopkins. The name of this illness has changed over time. It's morphed, and so it's confusing because people call it a lot of things. Many people still call it chronic Lyme disease, as Sam Donta, a good friend of mine, coined in 1997. It went through a phase where it was called post-Lyme syndrome, then post-treatment Lyme disease syndrome. With COVID, it started being called long haul Lyme, persistent Lyme, and now recently, the National Academy of Sciences is lumping it together with other infection-associated illnesses and calling them infection-associated chronic illnesses. To me, it doesn't matter what you call it. What matters is that we recognize that it's real, it's important, and it's a serious disease. So what is this illness, this disease? In the research setting, I'm going to be calling it post-treatment Lyme disease because we use a research case definition for research, but you can substitute chronic Lyme disease for this if that's what you call it. It doesn't matter. It's the patients that don't get better, that have fatigue and pain and memory problems. And these people with post-treatment Lyme disease, those symptoms are all worse than the controls in our studies without Lyme disease. But interestingly, they're very similar to long-haul COVID patients. Hence the trend to discuss these in the same context, because long-haul COVID symptoms look just like long-haul Lyme symptoms: fatigue, pain, brain fog, trouble sleeping, neuropathy. And so long-haul COVID patients, long-haul Lyme patients have these symptoms, and they're much worse than the general level of fatigue and pain in the general population. Sure, people without these illnesses have some fatigue, but it's generally much milder and much less important in their health. So chronic Lyme disease is a spectrum of many heterogeneous etiologies, or pathophysiologies, I should say, in other words, mechanisms. And the way to study that is to have a research case definition. So we study chronic Lyme disease by creating research case definitions for the research part of what I do here. I'm a physician half the time here, but the other half of the time I'm a researcher. And when I'm doing researcher, we use research case definitions to define post-treatment Lyme disease. In other words, you have to have had Lyme disease, you have to have the symptoms, you must have been evaluated to exclude other things, Interestingly, the antibody tests are not part of the case definition, because remember I told you again that the antibody responses don't correlate with the illness after treatment, especially early treatment. So we have a research case definition, and we designed this research study that I'm going to spend a little bit of time on because we think that this is the definitive study in North America to answer the question, is chronic Lyme, post-treatment Lyme, a real disease? This was a study we started many years ago, and it was designed to study that this research case definition of people that had, in this case, early Lyme disease with the rash that got treated. So this is studying people that have been treated appropriately, actually at the earliest stage, and then get followed for 6 to 12 months to evaluate how they do. Now, these patients are under the care of their regular physician as well, so they may get treated or by their physicians during this time, but for the research purposes, they're all treated with doxycycline and all followed up. And the question is, how many of these people would still have symptoms 6 months later? And we found that, and this is a lot of people, this is 234 patients with early Lyme disease, that 57% returned to their health. In other words, at the end of 6 to 12 months, they felt fine. It's like they never had Lyme disease. We call that the return to health group. A smaller group, 30% had some symptoms like fatigue and achiness, but it did not impact their quality of life. And so they didn't meet the research case definition. And in fact, some of these people probably had symptoms that didn't have anything to do with their Lyme disease. It could have been the fatigue or pain of, being a 65-year-old person. But some of them may have, but it didn't impact their quality of life. The group that met the full case definition that had symptoms and a decrease in quality of life accounted for 14% of the people. This, we think, is the first definitive proof that post-treatment, post-doxycycline treatment, significant number of people develop this chronic illness. And we were able to say that because we also have controls in this study. The controls here were followed the exact same protocol, but the controls, of course, didn't have Lyme disease at the beginning. And the rate of these symptoms and quality of life changes in the controls was only 4%. Now, whether that was due to something else or some other illness, we don't know, but it wasn't due to Lyme disease because we followed these people. And this was also pre-COVID, so it wasn't due to COVID. So significant numbers of people, much higher than the controls, develop post-treatment Lyme disease. And their fatigue levels and muscle pain levels in the people with Lyme disease was much higher in the controls, again, showing significant symptoms much higher than controls. And on questionnaires, we could show and validate questionnaires that they had higher pain levels, that their health-related quality of life was impaired. And so we think this is the gold standard study that says that post-treatment Lyme disease, i.e. chronic Lyme disease, is real. And the rate again was 13.7%. I'll point out something else that independently of Lyme disease being a risk factor, it was more likely to occur in women than men. So female sex is a risk factor for post-treatment Lyme disease, and having a prior traumatic life event in your past life history was also a risk factor. But these two things were controlled in the overall analysis. So these were not the cause of this 13.7% increase in the Lyme patients because we controlled for these things in the regression model. The other really important thing is that we weren't the only one that found this. Gary Wormser published about the same time his series, a similar design trial, although he used just chart assessment and review of his records, and he actually got a rate higher than us. He said 20% of his patients had post-treatment Lyme disease by chart review. There are some caveats to our study. We're unable to assess for co-infection in this study, and remember, this is ideally diagnosed and treated Lyme disease at erythema migrans stage. The rates are probably higher in late diagnosis of neurologic disease. And so these results can't be generalized to the community setting where there are high rates of misdiagnosis and delayed diagnosis that were not present in this ideally designed study. So why is this study so important? Well, one, I think it proves that post-treatment Lyme disease is real, but two, these 14% of people, we have blood samples that can be used to study the mechanisms of post-treatment Lyme disease, which is what I'm going to talk about now. We work with many collaborators to look at these mechanisms, and the possible mechanisms are heterogeneous. We're open-minded to the possible mechanisms of post-treatment Lyme, of this chronic illness associated with Lyme disease. They could be microbial mechanisms related to persistence of bacteria or bacterial remnants. They could be inflammation due to dysregulated immune responses. They can be altered neural networks, which I'll show you some data on. And of course, all these things are impacted by the person's genetics, by their illness experience, and by the microbial factors. So a complex Venn diagram of what may underlie the mechanisms for this chronic illness, and they're probably all true. And they're probably all different for every patient. Some combination is going to be uniquely at work in each patient. So we already proved and published in the past, and I won't review, that some of these mechanisms are at play. We've shown elevated cytokines in people that develop post-treatment Lyme disease, CCL19. We showed altered gene regulation and transcriptome patterns with Charles Chu that seem to correlate with post-treatment Lyme disease, changes in the metabolism and metabolome, and changes in the microbiome. These have all been published from the SLICE study that I just showed you, and again are proof that there's a biologic background to this disease. It's not just in the patient's heads, which is what I'm going to harp on from now on, is that there's a biology that we're disentangling that's behind this illness. We're really excited to tell you we just received our first NIH R01 grant in the last year to investigate some of these mechanisms. And we have three aims in this grant. One is led by Allison Redmond to develop a risk factor score to help clinicians diagnose who's at risk to develop chronic Lyme disease after their initial treatment. And this is a Framingham type study to look at risk factor scoring. That's our first aim. Our second aim is to look at autoantibodies, to look at mechanisms of persistent inflammation. And our third aim is to look at metabolic changes in the immune system that may be associated with immune dysregulation and development of post-treatment Lyme disease. We have an amazing group of researchers that we've built up over the years: Allison Redmond, Livia Rosen, Alex Girgis, and Andrea Cox. And one of the things I want to point out is that, we've been doing this a long time, and finally, we're getting grants and able to hire these kind of world-class researchers to work on the problems further. One of these aims will include looking at serum cytokines and chemokines, as well as cerebrospinal fluid cytokines and chemokines, and looking at the hypothesis that interferon alpha may be involved in the group that develops post-treatment Lyme disease. We've already shown that CCL19 may be involved, and then also IL-23. So these are examples of cytokines and chemokines that we're going to be looking at further in our patient population, and also looking in cerebral spinal fluid from spinal taps as well. We're very interested in autoantibodies. We've previously published on PAD2 antibodies that were found to be elevated in people with neurologic symptoms of post-treatment Lyme disease. This study was a serendipitous finding where we were actually looking, an investigator was looking at multiple sclerosis at these PAD2 antibodies and wanted our Lyme samples as a negative control, but they didn't turn out to be a negative control. They actually were higher than the levels in multiple sclerosis, pointing out again that there's a biology at work in post-treatment Lyme disease. There's something changed in our patients, one of which are the development of autoantibodies, in this case, antibodies to PAD2, which has previously been associated with multiple sclerosis. So this has got us very excited about the potential for future and ongoing work in other autoantibodies. John Miller, one of our investigators here, is very interested in autoantibodies associated with arthritis and is doing a special Lyme arthritis clinic, which is involved with research now to look at swollen joints. He uses musculoskeletal ultrasound to demonstrate swelling in the joints. Swelling equals inflammation, and inflammation equals something's wrong. Again, there's a biology here. There's stuff going on in the synovial fluid. In untreated Lyme disease, there's bacterial infection, but then after treatment, there's also the potential for autoantibody formation. And John's just published an article looking at annexin A2 antibodies in post-treatment Lyme disease, and he's shown that in post-treatment Lyme disease patients, that these annexin A2 autoantibodies are higher over time than they are in the people that return to health, and much higher than they are in the healthy controls. So this is an example of a potential marker for post-treatment Lyme disease that may identify a subgroup that's at risk for ongoing arthritis and musculoskeletal pain. These antibodies also are associated with endothelial cell antigens, and this may link this autoimmunity to endothelial dysfunction, which you probably may be aware is a prime topic in long haul COVID, and may kind of tie together one mechanism among these similar illnesses. So autoantibodies and annexin A2 antibodies will be studying in depth further. We're now expanding this to citrulline-aided autoantibodies and RA33 autoantibodies. So a lot of autoantibody work. Allison has projects she's just expanding now that she's published on in the past, the differences in male and female risk factors and biology in Lyme disease, but is going to be expanding that. It actually turns out nobody's ever really looked at the difference between pre and post-menopausal women in Lyme disease. And we have that data from our SLICE study. So Allison's going to be examining not just male versus female, but pre and post-menopausal. We've already demonstrated that the risk of persistent symptoms is higher in women, but now she's going to be dissecting that in pre and postmenopausal women. She's also going to be working with our collaborators to look at autoantibody formation and also Lyme antibody formation and how that's different in women versus men. So the whole sex and gender-based biology of Lyme disease is going to be rapidly explored now with Allison on the project again. So I'm going to transition now to a different topic. This is something I've become very interested in recently, and the question is post-treatment Lyme disease, chronic Lyme disease, a psychosomatic illness. I'm always known it's not, but I've gotten much more interested in dissecting this fallacy since I started working with Dr. Glenn Treisman, who's a medical psychiatrist at Hopkins, who, when I asked the question, is post-treatment Lyme disease a psychosomatic illness, he's a pretty blunt guy, and he said, no. And, he said psychosomatic illnesses are distinct clinical entities to a psychiatrist. They're things like conversion disorder, malingering, pseudoseizures. He said none of that is what post-treatment Lyme disease syndrome is. So from a psychiatrist's point of view, post-treatment Lyme disease doesn't really look like a psychosomatic illness. The underlying pathophysiology is complex and it's heterogeneous, but it's not just due to mental problems. It's due to biology, which we're dissecting, autonomic dysfunction, musculoskeletal inflammation, as I told you. Now, what confuses people is that post-treatment Lyme disease does present a range of symptoms reported by the patients and is primarily a symptom-reported illness, and people have a different range of life experiences and personality types that shapes the way their illness is presented and experienced. But that doesn't mean it's a psychosomatic illness. It just means people have different ways of presenting their illness and living the experience of having a chronic illness. And so I asked Dr. Shrieve, I said, well, doesn't it look like depression? And his response is, well, depression alone isn't an adequate explanation for the range of symptoms seen in post-treatment Lyme disease. Albeit people with post-treatment Lyme disease and chronic illness do get depressed, and people have depression get post-treatment Lyme disease. But he said it's not an adequate explanation alone for the range and the multiple organs that are impacted by this process. For example, dysautonomia that I'm going to talk about more. So I just want to pound this home again. We don't think that post-treatment Lyme disease is a psychosomatic illness. The problem is, the way medicine functions these days is everyone looks at a different part of the elephant, and different specialists look at different things. So if you're a urologist, you look at interstitial cystitis. If you're a rheumatologist, you call it fibromyalgia. If you're a pain person, complex regional pain syndrome. POTS. All these things are different ways of looking at the elephant that is post-treatment Lyme disease syndrome. And the problem is our siloed medical care system doesn't put these all together into a synthetic operational definition of what's going on in our patients. So we just received a grant from the Stephen Alexander Cohen Foundation a year ago to design a model clinic for the evaluation of chronic Lyme disease. And what we're going to have started doing is trying to get away from this model of siloed medicine and knock the silo down. And so I want to report to you now what we're doing to try to get away from this model of, one specialist taking one thing and one specialist taking another, and doing a unified approach to what's going on with chronic Lyme disease. And an example of that is using one model to explain symptoms, which is the autonomic nervous system, which has a sympathetic and parasympathetic arm, and you can see these parts of the nervous system go to all parts of your body, to your face and brain, to your lungs, to your heart, to your stomach and digestive, to your adrenal, to your bladder. All these things are innervated by your nervous system and your brain through this autonomic nervous system. We think this is an example of how you have to approach this as a synthetic multi-system disease and not pick apart each part by a subspecialist, because the autonomic nervous system, which we think may be one of the key features here, goes everywhere. So Britt Adler is our autonomic nervous system specialist and is studying POTS, postural orthostatic tachycardia syndrome, using transcranial Doppler, tilt table testing, sympathetic ganglia analysis. We're doing small fiber biopsies for small fiber neuropathy. We'll be looking at dorsal root ganglia, again, trying to get at mechanisms that can tie all these symptoms together through the autonomic nervous system. When you look at dysautonomia in chronic Lyme patients, the post-treatment Lyme patients in green have dysautonomia levels on a survey called the Compass 31 survey that are much higher than controls and are similar to people with diseases like scleroderma that have a lot of dysautonomia. And again, this dysautonomia encompasses multiple organ systems: POTS and orthostatic intolerance, vasomotor, secretomotor, GI, urinary, eyes, tying together all these diverse symptoms that people before, doctors didn't understand how these could all be present in one patient. And so they must be psychosomatic, because I can't understand it if I'm, only a GI person and don't consider the other components of the autonomic nervous system. So we're working hard on identifying these dysautonomia features using survey instruments and then studies of the actual mechanisms. Very excitingly, we're tying together the brain problems in chronic Lyme disease to some basic biology through neuroimaging. And so Sherry Marvel, who's one of our really fantastic collaborators in neurology, has been studied in advanced brain imaging in the context of some of these complex symptoms focusing first on brain fog as a major symptom of post-treatment Lyme disease. And what Sherry's work is based on is that we know that neuropsychiatric symptoms are common in Lyme and chronic Lyme: cognitive fatigue, sleep disruption, anxiety, and depression. So we know the symptoms are there. We know that on cognitive testing, you can find abnormalities on cognitive testing that correlate with attention and verbal memory and working memory. Processing speed is low. And in our previous PET imaging studies, we showed that these changes may be due to neural inflammation. So Sherry Marvel has now picked up on the PET imaging work and expanded it to functional MRI imaging. And what we're now looking at is whether there's changes in the functional MRI imaging in people with brain fog by asking them to actually do cognitive tasks while in the scanner. So this shows MRI images of people that are actually doing calculations while they're in the scanner. We're making them work while they're being scanned. It's like doing a stress test for a cardiac workup. It's actually work while you're being scanned. And you can see that in the normal controls, you have certain areas of the brain that light up, but in the post-treatment Lyme, chronic Lyme patients, different areas of the brain light up, implying there's a difference in the neurocircuitry of the brain in the people that have this brain fog from post-treatment Lyme disease. Now, these images probably don't mean anything to you. They didn't mean much to me either. But when Sherry looked at these, she said, John, there's a striking issue here. The images that are different in the Lyme patients are actually in the white matter of their brains, not the gray matter. Now, the white matter is the circuitry. It's like the wiring that connects the different parts of the brain, and the white matter is not supposed to be affected in these illnesses. In fact, this was the first time white matter changes had been demonstrated. And Sherry published this as a first finding ever that post-treatment Lyme disease is actually affecting the white matter more than the gray matter, and that the changes in the white matter may actually be adaptive in the people that are getting better and correlate with actual repair and improvement. Again, putting a biology behind what's going on in these patients, and now an anatomic correlation, so that it's not just the symptom of brain fog or the survey of brain fog or even the cognitive testing, but actually neural anatomy that you can be mapped onto the circuitry of the brain. And the fact that white matter is involved actually makes sense to the patients, right? Because they've long described to us that things just seem to be slow, that it's hard to get things done, that's hard multitasking, that everything just seems to be like going through fog. Well, that's because their wiring is slowed, and their processing speed is slowed probably because of this illness. I'm going to transition now to treatment trials. Again, a sign of hope in the field. The Stephen and Alexander Cohen Foundation has funded a clinical trials network. The coordinating center at Columbia with Brian Fallon in this clinical trials network is now advancing pilot studies for the treatment of post-treatment Lyme disease and chronic Lyme, and started in 2021. And these are the studies that are being funded, pilot studies for trying to get treatment trials back on the map for what to do for people that don't get better after their initial standard therapy, and addressing all possible mechanisms, everything from antibiotics to vagal nerve stimulation, mast cell treatments, proteolytic enzymes, IV ceftriaxone. Again, not putting all our eggs in one basket, but recognizing there may be multiple mechanisms for chronic Lyme disease, and that we need pilot studies to start to explore what are options and treatments that can be proven and brought into treatment for our patients. Separate from that, we're also involved in a psilocybin study at Johns Hopkins, where the psychedelic group at Hopkins in psychiatry has already shown psilocybin therapy as an effective therapy for other illnesses, has a pilot study for use of psilocybin in post-treatment Lyme disease syndrome. That's the website to go to for that. And then our clinical trials network trial, which is looking at the use of tetracycline, extended course 3 months of tetracycline for post-treatment Lyme disease, which you can learn more at our website here. So I know I've been moving fast, talk fast, and let me give you some takeaways, and then we'll have plenty of time for questions. Here's some takeaways that I tried to emphasize. The bullseye rash is diagnostic of Lyme disease, but not the most common rash presentation. The rashes are usually not bullseye, but just round and red. And besides that, the rash is not always present and is more difficult to discern when present in dark-skinned individuals. The blood test diagnostics are problematic, and we still rely as a first step on clinical diagnosis and use of blood tests to confirm that, recognizing they don't confirm the very earliest stages of Lyme disease. Importantly, persistent symptoms such as brain fog after treatment are real, and I hopefully showed you today some research that shows that there's molecular and biologic mechanisms that are real that underlie persistent symptoms, that they're not psychosomatic, they're not the patient's fault, the patient's not making them up, they're not there just because the patient has a prior history of depression or anxiety, that this is a real biology of a real disease. The mechanisms, though, are complex, and we're untangling them. They can involve many things: immune system dysfunction, microbial mechanisms, neural network alterations. Sex and gender are likely important on their impact, and we'll sort these things out through our research, brain imaging, novel joint ultrasound, and autoimmune mechanisms, autoantibody discovery, and then very importantly, starting to do research in combination with research on long COVID and chronic fatigue syndrome, which share some of the same disease manifestations and mechanisms potentially. And so we want to learn from long COVID, and in fact are now embarking on some joint studies in the neural imaging, comparing long COVID patients to long Lyme patients. I want to thank Nancy Doherty for all the work she does on education, and remind you that we put out a newsletter and an impact report every year that you can sign up for that goes over much of what I've talked about today. Our funders are amazing, including the Kenny Family Foundation and others, and none of this would be possible without the individual donors that really, before we ever had an NIH grant, we were completely funded by individual and foundation donors. We've developed quite a big group of people at Hopkins now studying Lyme disease, and not just what I've been talking about in the School of Medicine, but also people in the School of Public Health and people in the Applied Physics Lab in the Whiting School of Engineering that are doing AI modeling for rash image detection. And these are some more resources, and I'll leave these up for you. Websites, including our website that has a lot of educational material, things about what to do after a tick bite, has our study information, and also has our rash hotline. And with that, I'm going to go ahead and open things up for questions.
Thank you, John, for this presentation. We have a lot of questions from the audience, and we are going to try to move through and get through as many of them as possible. We will be unable to answer specific patient care questions in this forum because, as Dr. Aucott mentioned, the illness is multifactorial. Every patient is unique and needs an individualized approach. But there's a lot of questions regarding the research and a number of different issues, and we will discuss as many of those questions as possible. So thank you for writing in, and continue to do so. So let me start. Is there a way to detect latent Lyme disease, or is there a problem with seronegativity?
So the holy grail of Lyme disease is detecting latent bacteria. It's a tough nut to crack. The best person at doing this is Monica Embers, who works in animal models. And the difference there, of course, is animal models, the Reese macaque monkey model and the mouse model, you can detect latent Lyme disease because you can do an autopsy, right? And so you have access to the entire organ tissue. But I'll tell you, even with that, Dr. Embers has a very difficult time detecting latent infection. In other words, it's not unusual to have to look at over 100 slides to find a bacterial organism. So when you translate that to humans, where we don't usually have autopsy material, it becomes an almost impossible nut to crack. Now, I'll say a caveat: the Barrier Lyme Foundation has sponsored a autopsy biobank of postmortem tissue. They are starting to look at, and just published a case report in the last month that you can look up. Liz Horn from the biobank is one of the authors, Monica Embers. And so there are a couple case reports, but they're just starting to come into the literature. In general, in a clinical setting like I'm in, taking care of people, there's no test to establish latent infection. That's the holy grail that we're trying to work on. Now, some of those diagnostic tests I showed you that are in the LymeX competition do look at direct tests for bacterial antigens and bacterial DNA, so-called PCR tests. And if those make it to the level of being able to detect the occasional rare organism, that's the hope. But you have to be able to find the needle in the haystack, honestly. It's a very tough nut to track. The seronegativity part of that, though, that's why those antibody tests aren't the answer, because if you treat early Lyme disease with antibiotics at the stage of the erythema migrans rash, you're not going to be seropositive more than half the time, even if you wait a month or two, because the early antibiotic treatment kind of blocks the antibody production to a level that's detectable. So, the antibodies are not the answer to finding latent Lyme disease. And, it's the holy grail that we're working on. But keep tuned for that,
And this is tangential, but similar. Why would someone continuously test IgM positive, say 5 positive bands on the Western blot, and never IgG positive?
Yeah, so that's a great question. So just a short background, medical students are taught that IgM antibodies are the first wave of the immune response. I remember that because the M stands for the Marines. They get there first. IgG are the regular army and take several weeks to get there. But again, Borrelia burgdorferi is a professional immune system evader. And Nicole Baumgarth, who's now here at the Hopkins School of Public Health, is one of the world's experts on showing that Borrelia burgdorferi infection in mice, she's a mouse immunologist, changes the ability for the normal progression of IgM to IgG antibody production in mice that are infected with Borrelia burgdorferi. So remember, Borrelia is a professional immune system disruptor and evader. And in mice, she's shown that it prevents the formation of the high specificity IgG antibodies. And often what you end up with is prolonged IgM antibody production, which isn't supposed to happen, right? In medical school, you're taught that the IgM just comes up and then goes down as the IgG takes over. That just doesn't happen in Lyme disease with early treatment, especially. And so you often are left with persistent IgMs and no IgGs. And Alan Sears' work has shown that people have IgM antibodies 20 years later from his long-term follow-up studies in like 20% of the people. So the finding of an IgM antibody does not mean you have an acute infection. It could just be left over from your old exposure and this disrupted immune response that Borrelia seems to be a professional at creating this immune dysregulation.
Thank you. So your biorepository has generated a lot of takeaways in terms of biologic mechanisms, and yet you have not been able to explore everything that you wish. If you were able to fund your next studies, what would they be, or what are you interested in pursuing that you haven't been able to fund presently?
So the biobank, our SLICE study was started actually all with really philanthropy and then some big foundations, really until a couple of years ago when we got our first federal grants. And so we never had enough money to do the complete kind of studies that I would have liked to do. For instance, we never really had funding, and still to this day don't have funding to look at the role of co-infections, for instance. So we would love to use the biobank to then dive into potential co-infections and their role in the mechanisms of persistent illness. So, that's a crucial thing that we haven't been able to do. We've written 2 big grants to expand our work to look at co-infections and have not been successful in getting funding. So that's an example of one thing. You'd like to, I'm greedy. I'd like to do everything, of course, but we do what we had the resources to do, and so that would be an example. And I think the other thing is to get, I've hinted at that, but to really dive deeper into the differences in sex-based differences in the illness that really nobody's looking at.
And what about comparisons to long COVID?
Yeah, so when you look at these illnesses, there's more similarities than differences. I actually learned this from talking to Peter Rowe, who's a world's expert on chronic fatigue syndrome. And he said, John, your chronic Lyme patients look a lot like my chronic fatigue patients. They have post-exertional fatigue, they have orthostatic intolerance, and often when we table test them, they have postural orthostatic tachycardia syndrome. He goes, you should look for that in your chronic Lyme patients. And lo and behold, when we started looking at it, we found it. And so not in everyone, but in a significant subset. And so that was an example of how there's overlapping mechanisms probably in these patient populations. And then of course, when COVID came out, long COVID is even more strikingly similar. And that's where we learned the lesson about dysautonomia. Dysautonomia is found a lot in long COVID, and now we're finding it in chronic Lyme. So what we're doing is, the nice thing about being at a place like Hopkins is there are people looking at long COVID. They're looking at the inflammatory mediators, the cytokines and chemokines, and actually the metabolism changes. And so we're going to be comparing our results with the long COVID results. And then Sherry Marvel is actually writing a grant right now to compare the neural imaging, functional MRI imaging in long COVID and long Lyme side by side. So I think there's going to be a lot of overlap lessons there that are going to inform each other. Because again, it's not going to be one single answer, right? This is a heterogeneous population, and some of them are going to look like chronic fatigue type problems, probably. Some are going to look like dysautonomia problems, and others are probably going to look like, bacterially mediated inflammation or persistent bacterial antigens and persistent bacteria. And, that's also something that's being explored in long COVID, viral persistence. So there's numerous overlapping potential mechanisms here. And the good news is long COVID's got a lot of funding, right? So they've got a lot of resources that we're going to try to tap into their research to inform our research.
Excellent, thank you. There are a number of questions about doxycycline, including whether it's appropriate for chronic Lyme disease, or some questions around wanting you to address the efficacy or lack thereof of treating a tick bite with only 1 to 2 doses of doxycycline and without any follow-up. So maybe you can touch on that.
So that was 3 questions. So you may have to remind me of the first one by the time I get done with it. So I'll start with the doxycycline for prophylaxis. Actually, Betty Maloney was at the Delaware Lyme Conference, sponsored by the Delaware State group last week, and she did a wonderful presentation comparing and contrasting the treatment recommendations of the ILADS group with the Infectious Disease Society. And one thing they talked about was prophylaxis, and talked about the difference in the 2 recommendations where, the recommendations in the IDSA guidelines are for single dose doxycycline, and Betty laid out an argument about from mouse model data about whether it might be preferable to do more longer course than a single, but that's not been studied and that's not part of the official recommendations. But it just points out that there's a lot we don't know, right? And so people have different recommendations, and so I'd refer you actually to Betty Maloney's work. She's actually quite an expert on that and lays out a nice discussion. Betty always lays out the evidence-based aspects of things and where the evidence is there and where things haven't been looked at. And that's an example of where longer courses haven't really been looked at. So I already forgot the first two questions, sorry.
They were on, is doxycycline appropriate for chronic Lyme disease? Are 1 or 2 doses of doxy enough or not? And I think you addressed some of the longer term dosing.
Yeah, so chronic Lyme, we're actually, one of the studies I showed you that we have an IRB and actually an FDA approval for is studying tetracycline, which is a doxycycline cousin, and using 3 months of tetracycline in post-treatment Lyme disease. That's not for clinical use. It's an IRB approved investigational study, but I can tell you the rationale. The rationale is doxycycline and tetracycline are pretty interesting chemicals. They're not clean. They do lots of things. They're antibiotics, but they're also pretty impressive anti-inflammatories. Another related drug, minocycline, actually has been shown to improve the outcome from stroke and things like multiple sclerosis. So they're anti-inflammatories and antibiotics, and we're interested in that combination, mechanism. And so that's how we got the IRB approved to study 3 months of tetracycline. So I think, there's approaches like that make sense to study that have never really been studied. And that's one of the studies we're doing at Hopkins.
There's a question about what tests would you do if Lyme disease has gone to the heart?
Right. So cardiac Lyme is really important. The acute phase is often in association with, a recent acute infection. In other words, it occurs 4 to 8 weeks after the acute infection. And so the suspicion comes up in somebody who has just had acute infection or is acutely infected, who has heart symptoms like palpitations or shortness of breath. And the first test you do is a EKG, because the Borrelia preferentially impacts the conduction system, the electrical system of the heart, and it shows up with conduction system delays on the EKG. So that's a simple and cheap test that should be done in people that are systemically ill that have cardiac symptoms. And the big pediatric group, Lise Negrovic, who runs the pediatric consortium in emergency rooms, has published. You can look up her work, Lisa Negrovic, and shown that using electrocardiograms in the emergency room setting, you find a lot of cardiac Lyme disease. This is in kids actually who present with acute symptoms and conduction problems. The clinical symptom can be palpitations or often a slow heart rate, because the conduction system abnormalities slow the heart rate down sometimes. And so doing an EKG is probably underutilized in the acute setting. If it's more in the subacute or chronic setting, you would do tests like an echocardiogram to see if it's impacted the heart function, the muscle function. And then if that's suspicious, then rarely, but occasionally we do PET imaging to look at the heart muscle function.
There's a number of questions about how can we better educate the medical community, and a lot of examples of folks going to the ER or walk-in clinic, and particularly in states where it's less common or less acknowledged, such as North Carolina. And how can we improve medical education? Every year you come to this meeting and you have advances in research and knowledge, and yet how do we get that to the medical community?
That's a multifaceted answer, I think. I mean, in the medical community itself, that's done through specific mechanisms that, you know, what people like me try to do, right? And then there's also national organizations. And I have to say, Health and Human Services and the CDC are more involved recently in education. But I think it's really important that, you know, they work with patients to make sure the right education is delivered, and that there's patient input into educational material on those levels. And then, you know, I'm not a, you know, a politician, but, you know, I think patients need to be advocates, and they need to be advocates that, you know, most education is done through public health departments on a state level. And so I think there is a role for patients to be active on a state level. That's actually what happened with this program in Delaware. You know, a patient advocate got active in the state level in Delaware, you know, put on some amazing CME course last week. They had like hundreds of state healthcare providers attend, because it was done through the state level, through a, you know, a patient advocacy at a state level that that in a positive way got the state medical you know, organizations to help sponsor a, it's really amazing program. And I think that's the kind of thing that should be done on a state level all around. Because unfortunately, you know, public health is delivered on a state level more than a national level in many ways. So state level, CDC, Health and Human Services, people like me through our medical societies and lecturing, it's, you know, it's constantly, you know, talking the story and getting the word out.
There's some questions about misdiagnosed MS, that some cases of MS, or people are diagnosed as MS and then it turns out their white matter lesions are Lyme disease.
That's right. So classic MS is usually not a difficult differential from Lyme with an experienced neurologist, classical MS. But there are always cases that aren't classical, right? That are in the gray zone. And we work with a neurologist that, you know, really is an MS expert. And that's the kind of person you want to be involved in a you know, an atypical MS case, or an MS case where the person had, you know, a complicated Lyme history before the MS. You know, you want to work with somebody in a, you know, in a referral institution that has those kind of neurologists, because, you know, run of the mill MS shouldn't be an issue, and the MRIs should distinguish the two pretty well. But it's those atypical cases where I rely on the neurologic experts that have, you know, they're really MS neuroinflammatory disease experts, you know, that are used to looking at MRIs, and in those kind of gray cases are the kind of people you want involved.
There's a few people asking if they never saw a tick or never had a rash, but they have a lot of the symptoms of Lyme disease. Might they still have Lyme disease, or what do they do?
So only 30% of people that have Lyme disease saw a tick bite. So the absence of a tick bite is totally unhelpful. But we like to think that the majority of people had one of the first telltale symptoms or signs, like the rash. But I already showed you data that a lot of people don't see or recognize a rash. So hopefully they have the symptoms, but I already showed you data that the symptoms sometimes aren't specific enough to lead to a diagnosis. So that's a good question, because we see every few weeks a patient that didn't have a tick bite, didn't have the rash recognized. They may have had it, but it wasn't recognized, and went on to develop chronic Lyme disease. We know that's true because that's how people end up with late Lyme arthritis 6 months later, right? Those people that develop late Lyme arthritis in their knee 6 months after a tick bite, by definition, they didn't get treated for the tick bite, because if they had, they would have never developed late Lyme swollen knee arthritis. So it still happens. So the answer is yes, it can happen. The answer about when to test, though, for symptoms like fatigue is controversial, honestly, because it gets down to statistical arguments about how well the tests perform in people with symptoms like fatigue that are not just due to Lyme disease, right? You know, if you're a general interest in seeing people with fatigue, there's a lot of different things that can cause that. And so whether or not you do a Lyme test on everyone with fatigue really gets down to what doctors call the pre-test probability. In other words, how likely it is to be Lyme disease. If there's almost no pre-test probability, then you shouldn't do the test. But if there's a high pretest probability, like the person lives in New Jersey and they're a turkey hunter and they crawl through the brush every summer hunting turkeys, you know, then their pretest probability is not insignificant. And that's the kind of person you definitely would want to do a Lyme test on, even if they never saw a tick bite or never saw a rash. So it's why being a physician takes talking to the patient and really formulating their story and their risk factors for different diseases. But you don't exclude Lyme disease by the absence of a tick bite, I'll tell you that for sure.
Is there any data yet on the use of external vagus nerve stimulation, low level, for the treatment of post-treatment Lyme disease?
So that's the pilot study Brian Fallon's group is doing at Columbia, and I think UCSF has signed up also to be a site for that study. So that is in the pilot phase study through the Clinical Trials Network right now.
So no data yet, but stay tuned.
Exactly. Yep. Yep.
Let's see. Symptoms resolve after treatment, but then emerge years later.
Say that again, sorry.
Have there been cases of Lyme disease where the symptoms disappear or resolve after treatment, but then reemerge years later?
We think we see that. The longer the interval period is, the harder it is, though, to give causation because other things happen in those intervals, right? So, you know, if it's been 10 years since the Lyme disease, then a lot happens in those 10 years that could also be at play. But we definitely see people that we think the symptoms go away for months or even a year or two and then come back, and we have no other explanation for them other than it's post-treatment Lyme disease. The official research case definition says that it has to come on within 6 months and then last for 6 months. But we see patients where it doesn't seem to come on for a year or two all the time. But you have to be really careful because other things could have happened in that couple of years that, you know, the bottom line is chronic Lyme disease is a diagnosis of exclusion, right? There's no blood test for chronic Lyme disease. So it's what doctors call a diagnosis of exclusion. And I'll tell you, you know, I've evaluated hundreds and hundreds of people for chronic Lyme disease in my career. And a lot of them have chronic Lyme disease, but a lot of them have something else because, you know, the patient doesn't know what they have. They just know they don't feel well. And just like a patient that comes into the emergency room with chest pain, not all of them have a heart attack. Some of them have acid reflux. Some have dissecting aortic aneurysm. Some have, you know, costochondritis. And so I've made every diagnosis in the world in somebody who came for evaluation of chronic Lyme disease. And it's a diagnosis of exclusion. So you need a good internist to consider all possibilities, just like you do for any illness, whether it's chest pain or, you know, numbness. Every illness deserves a initial comprehensive evaluation because the more you look, the more you find, right? But if you exclude other diagnoses and the patient has a risk for Lyme disease, then that's the patient you do the testing on and try to get the old medical records to find the smoking gun of the original infection, then that's how you make the diagnosis. Unfortunately, there's not just a simple blood test to diagnose chronic Lyme disease.
There's some questions about brain fog, and if you could help define it so they understand what that is. And then also, might the possible endothelial dysfunction impact neuroinflammation?
Well, I'll answer the second one first. The answer is yes. Yeah, that may impact neural inflammation and glial cell inflammation. It may be one of the major mechanisms. That's what we showed on that PET image that I showed you. The brain fog is actually hard to define, it turns out. Is it, it's that sense that people have a hard time multitasking, or it may involve memory problems, or it may involve, just feeling like they're in a fog. When you do cognitive testing, it turns out the cognitive testing that's formal, cognitive testing, intelligence testing, is not drastically abnormal usually, but if you look carefully, it is abnormal in many of these patients. And where it's normal is in processing speed and certain types of memory, but especially in processing speed. And that kind of goes along with the fog, right? It's hard to multitask or keep things in your mind when everything's moving slowly. So that functional MRI tasks that we ask people to do when we're doing the functional MRI studies I showed you, they're doing a task. They're thinking during the scan, and the thinking task we give them measures something called working memory. Working memory is sort of like the RAM of your brain. It's the stuff that allows you to hold data in your brain and manipulate it. And with brain fog, it's hard to hold things in your brain and manipulate them. So that's why people have with brain fog, like will walk into a room and forget why they walked into the room, right? Because it dropped out of their working memory. And so we ask them to hold things in their working memory while they're in the scanner and manipulate the data in their working memory in real time. And that recapitulates the brain fog, because with brain fog, it's hard for you to hold things in your working memory, and they drop out and you forget what you were doing, or you can't juggle 5 things at once in your working memory the way you used to. But it's subtle on cognitive testing, because it's not like people don't have dementia. They don't have, brain damage like you'd see from, an encephalitis case where, they can't score on intelligence testing. The people get the answers. They have to work harder because everything's moving through a fog. So they usually get the answers right. They just have to work a lot harder, and things move slower. And so it's harder to get to the answer. I don't know, does that explain it a little?
Yes.
Okay.
Excellent. Thank you. So there's a few questions about Lyme disease and autoimmune diseases, in that Lyme disease can potentially trigger autoimmune diseases, and wondering if there's any connection to specific autoimmune diseases, and whether your autoantibody research is trying to address some of those questions.
Yeah, so John Miller, our autoimmune rheumatologist in the center, so he studies autoimmunity in classic Lyme arthritis after treatment, but he also studies autoimmunity. There seems to be a group of people that develop what's called reactive arthritis or psoriatic arthritis. And that's a specific kind of arthritis that seems to be triggered by Lyme disease. People that are especially prone to that, we think, are people with psoriasis, because psoriasis, the skin condition, is associated with an arthritis. But we tend to see it more after people have Lyme disease, that they develop this psoriatic arthritis, especially if they've had psoriasis. But they also develop a psoriatic-like arthritis without the psoriasis. It's called reactive arthritis. And it's hard to diagnose. That's why I showed you those pictures of him doing ultrasound with the ultrasound images. You need an ultrasound to make that diagnosis often, because the inflammation can be subtle, and it's often localized around the tendons and causes a tendonitis. So that tendonitis is hard to detect on clinical exam, and the ultrasound is often a benefit. So the answer is yes. We think there is a subset. Again, gets to the subset issue of people that will develop a kind of a classic psoriatic or reactive arthritis. And that's a classic kind of arthritis that we know how to treat, actually, right? I mean, in a rheumatology clinic, people are being treated all the time for psoriatic and reactive arthritis as a classic autoimmune illness. So just because the Lyme disease was there and triggered the psoriatic arthritis, once the Lyme disease is treated, we feel strongly that then the psoriatic arthritis should be treated the way rheumatologists always treat psoriatic arthritis, which is with inflammatory, mediator inhibitors and drugs that turn the overactive immune system down so that joints and tendons aren't inflamed and damaged from the inflammation.
There's also some questions about post-mortem tissue donations, and if someone is interested in that, where would they go?
Yeah, so it's the group through the Bay Area Lyme Foundation, and Liz Horn is the principal investigator. So if you Googled her and the biobank tissue bank, Liz Horn and Bay Area Lyme Foundation. I don't have their link, unfortunately, but they just published a paper in the last month on that, and I'm sure there's contact information there, hopefully.
And another question about your work in conjunction with Canada or Canadian Lyme disease organizations. Can you talk about that? And there's interest in if someone's in Canada, where would they seek information?
Yeah, so the Canadian group is a wonderful group. They're very enthusiastic about research in Canada and the emerging, epidemic of tick-borne disease in Canada. And the group now is the branding of it, I think, is TickNet. I think that's the branding. And they have a meeting in Vancouver this fall. And while I'm talking, I'll try to look up the TickNet. And that's what I would search. And they're really a wonderful group, and they're very, again, they're very concerned that this is a real problem in Canada, which, originally they were met with skepticism as well, because, this is a dynamic process, and the disease is expanding geographically into Canada. But initially there was skepticism about how important it was. It's clearer that it's important. So so that, yes, the answer is yes.
All right, I'm going through a lot of questions. There's over 100.
Yeah, it's called TickNet, 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 and they have a scientific symposium coming up in the fall. TickNet Canada.
So you've answered a lot. Let me just keep working here. There's a number of questions about the vaccine, some skepticism because of previous vaccines and reactions from people who took the vaccine. And I know there's a number of different approaches out there.
Yeah,
Is
that's
the
yeah.
Go ahead.
So there is a Valneva and Pfizer have a vaccine in phase 3 trials right now, which is advanced. That means they're testing it in thousands of people with the idea of getting it approved in the next several years. It's an OspA vaccine like the prior vaccine, but it's different than the prior vaccine. They've removed the epitope that the antibody formation that drove the antibody formation that had been alleged to be associated with side effects. They removed that part of the antigen epitope. So they feel the issue of the kind of antibody side effects from this one area of the OSPE. And they also have expanded it so it covers strains from around the world, so it can be used in both continents. And so they think they've addressed the concerns. So I think there's a lot of hope that that will make an impact. I have hope for it. I'll tell you why, because the other preventive measures just don't work. You talk about public awareness. I mean, I spend so much time doing public awareness talks about prevention, and they just don't work. There are things that work. I mean, treating your clothing with permethrin, which is a caricide that kills ticks that you can treat your clothing with. It's called permethrin. I do that all the time, but to do it, you have to wear long pants in the heat of, July in Baltimore, and nobody wants to do that, right? It's hard to get people to wear long pants treated with permethrin when they want to be outdoors in short pants and flip-flops. So, prevention is a very difficult sell to do. Doing tick checks is hard to implement. And so I honestly think a vaccine will be the most effective preventive. And it's important because we spent a lot of time tonight talking about how a tick bite or a rash is not a reliable way to diagnose early Lyme disease. And so it'd be awfully nice to prevent the cases before you ever get them. There is also work being done on compounds that kill ticks when they bite you. Sort of like the things that are used in dogs sometimes. So there are other alternatives under investigation for prevention that are work on killing the ticks when they bite you too. I think we have to develop something like that though, because what's called personal protection with long pants and tick checks and all that, it's just so hard to implement. It's hard to get reliable implementation.
So there's also some questions about how we build the infrastructure to move forward towards more expanded treatment trials, and also in this framework of trying to be interdisciplinary, break down some of the silos and actually work on the whole person.
Yeah, so when you asked me what my dream was, Nancy, that's actually my real dream. Is, because I'm a clinician at heart. My real dream is to develop, a series of clinical trials network. I'm sorry, it's a network of, academic excellence, centers of excellence. That's really my dream because, you remember Lyme disease started the same time as HIV/AIDS. I happened to be a medical student at the time, and I grew up with HIV/AIDS and Lyme disease. And the resources that were brought to bear in the academic centers of excellence and the clinical trial network that were developed for HIV/AIDS were just spectacular, right? And, it was a joy to be involved in the early stages and watch the advances being made, because of the incredible infrastructure that was created. And none of that ever happened with Lyme disease, right? Because of many reasons. And so my actual real dream is that we would create an academic centers of excellence network like there are for all diseases, right? I mean, look at the oncology space where there's oncology centers of excellence and treatment consortiums. I mean, that's the way you solve problems. You don't solve them on one-offs at one place and one-offs at another place. You bring together big networks, and that's my dream, honestly. But that's a dream that have no power over.
Well, I think a lot of people have that vision too, because there's a lot of people out there that are looking for help and improved treatments, improved diagnostics, and better recognition of their illness that is not psychosomatic, but driven by biologic.
I mean, I honestly think we know how to do it. We did it with AIDS. We do it with a cancer. I've lived both of those diseases, and see them absolutely transformed. And we can do it. It's just the getting the willpower to initiative to fund what it takes, which is, big.
Well, thank you. Why don't we end on your big vision, and we'll turn it back over to Phil Kenny, who will give concluding remarks. And John and I want to thank Shireen and Gina and Phil and all of you for attending this webinar. We hope you've learned something, and we hope you all get better. Thank you.
Thank you.
Thank you, Nancy. And thank you, John, again for coming, and all of the research you've done and care for the Lyme disease family here. Nancy, I want to thank you for all you've done over the years to support our efforts. And I want to also thank Eric Weinstein, who's behind the scenes and does all the technical stuff for us, our website. And he's going to be putting this together, probably be released on our website within the next 30 days. We'll let you know, and you can share it with others. Also on our website, which is limecenter.org, there are dozens of other presentations that are very helpful for not only Lyme disease, but any chronic illness, neuropathic consequences of vector-borne illnesses, cognitive behavior intervention in chronic illness management, healthy foods to fight inflammation, and there's more and more and more there on our website, limecenter.org. We're having our annual fundraising. So we're going to, you can donate online or mail a check in. The information is on our website. So for every $1 you donate, it'll be doubled. So a $20 donation will be 40. So we appreciate your support. It's been supporting us for 8 years, and we appreciate those who've been supporting us for years. I want to thank you again, John, Nancy, Gina, and of course, Shireen. Thank you all for coming tonight and joining us. And we all wish you well and good health. Blessings to you and family. Good evening.